Morning, everyone. Can you guys hear me? It's a hard act to follow. All right. Well, thank you for coming. My name's Luke. I'm the ultrasound director at the University of California, Riverside Emergency Medicine Residency. And although I don't have any official disclosures to make, HCA does own the hospital where our residency is, because they may or may not be paying for my trip to SAEM. I'm having to use their slides, so I apologize for the glare of the white slides if you're trying to take pictures. Also, I'm using QR codes, so if you have your phone, you can take your camera out, point it at the QR code, and then a little icon will appear. If you tap on that, it'll take you to the article, such as this. So this QR code right here, let's try this. Right there. That will, here we go. If you hold your phone up, it'll take you to this website, which will give you some great parenting advice. So here's my, my first parenting advice for you guys. Oh, I'm back. So even though dogs like them, shoes aren't for teething for babies. Today we're going to talk about, whoa, what's going on? Here we go. A common complaint in the pediatric emergency department, which is the pediatric limp. We're going to focus primarily on the hip. Something's going on with my slides here. Sorry, guys. There we go. Okay. We're going to look at some of the evidence and technique behind point-of-care ultrasound, otherwise known as POCUS, and many of the critical and common pathologies for the hip specifically. One of the main causes of pediatric limp that we don't want to miss, of course, is septic arthritis. And many of us use the clinical presentation and add in the Coker criteria. So that's, of course, fever greater than 38.5, non-weight bearing, ESR equal or greater than 40, and white blood cell count greater than 12,000. And the original retrospective study showed that if you had all four criteria, the probability that you had septic arthritis was pretty high. However, another retrospective study by Lumen et al. Called this into question, so many of us right now are probably using a fifth criteria, CRP, and if that's elevated, that has been shown to be pretty predictive. So then someone came along, Zamzam et al. They studied if we add in ultrasound, is there a diagnostic benefit to this? So this study, they took your clinical gestalt, some laboratory findings, and X-ray findings, and found a sensitivity and specificity for septic arthritis of about 74%. Then they added in an ultrasound, and they said, is there any benefit to that? And they found that it boosted the sensitivity and specificity into the 80s. So if there is some diagnostic benefit to using ultrasound, then the next question is, can emergency physicians use it? Can we perform that exam? And this is a small study, but they found that identifying the effusion was relatively easy. And these were novices. There was 2 pediatric emergency medicine attendings and 1 PEM fellow with minimal training, and they reached sensitivities and specificity in the 80s and 90s. But I think this also shows us, because that isn't perfect, that like other point-of-care ultrasound examinations, it's really important that you keep honing these skills, that you keep repeating this, and try to look for these subtle abnormalities that we can easily miss. So how do you do it? It's pretty straightforward. You don't have to do a comprehensive hip evaluation like is done for different techniques like developmental dysplasia of the hip. All you have to do is position the patient supine. If it's a little toddler, if you can lie them down on the patient's parent, so I just have the parent lie down on, and baby can be on the torso. Some argue for having the hip slightly flexed and internally rotated. Others argue for just full extension and actually slightly abducted. But the truth is, it's a toddler, and you just have to distract him. So get an iPad, use some warm gel, keep your hand on the clip button, because as soon as you put that gel in there, that baby's going to move. So try to get your clips as quickly as you can. You want to take a linear probe, a high-frequency probe, or curvilinear low-frequency probe if it's a larger child, or especially if it's adult, and place it anteriorly on the thigh, and then you want to scan in a sagittal plane. And you're just going to scan cranially until you lose that hyperechoic appearance of the femur, and then rotate into an oblique plane, so your long axis on the femoral neck. And what you'll see is this. Finding the femoral neck is pretty easy, but the trick here is because you're dealing with a pediatric patient, you're running into cartilage and growth plates, so sometimes teasing out the anatomy of the picture is a little bit difficult, so let's go through that. So the first thing that we see here, in the near field, we can see the iliopsoas muscle. And then if we go to the far field, we can see the femoral neck, the femoral head, our growth plate in between, and then in between the bone and muscle, we've got our joint capsule, which is this potential space, so if there is an effusion, the synovial fluid will accumulate there. So that's what we're looking for right there. So if we look over at the normal side, again, we're actually starting to see the acetabulum sneak into the picture here, and I'll show you a clip in a second where you'll get to see more of that, but not much of the acetabulum in this picture. Again, the iliopsoas muscle, the bone, and then in between, our joint capsule. And then we measure anteriorly at the level of the humeral neck. So right there. Right there is where we're going to place our measurement. And the key is you really want to come down here to where the femoral neck is sloping, and that's where you want to place your measurement. If we look over at the pathology, you can see the area where the greatest effusion is right down where you see the femoral neck slope. So an abnormal is going to be greater than 5 millimeters. Uh-oh. Sorry, guys. There we go. Or greater than 2 millimeters when you compare it to the normal side. So thankfully, we've all got a contralateral side, and usually there's not bilateral effusions, so you've got something to compare it to. And I want you to look closely at this because this is key. You want to fan to try to avoid anisotropy, so that's the concept where you've got your ultrasound waves have to hit something perpendicular to get a really good image. So if we look at the normal side here, you can see that as we fan, that internal echo disappears. So we see the echo, and then it disappears. So you may get fooled and think there might be an effusion when the echo is gone. So make sure you fan to rule out that anisotropy artifact and make sure that there's not an effusion there. But also, you've got to maintain that nice curvature of the femoral neck. So if I can get this to stop here. So we can see the curvature here of the femoral neck. If we follow it out a little bit farther, it will flatten out. And as it flattens out, it can artificially make this joint capsule appear bulging. So you do want to fan to get rid of anisotropy, but when you make your measurement, you want to make sure you see this nice curve. So normally the anterior joint capsule, it looks concave, but when you fan, of course, you can make it bulge. The true intracapsular effusion, it's always going to be bulging. It's going to look convex. And in transient synovitis, routinely it's going to be anechoic. But sometimes you will see some internal echoes, especially if it's a complex effusion. For adults, the measurement's 7, but adults, it's a little bit easier. If you look at the anatomy, you can see the acetabulum here, you see the femoral head, and then the neck sloping down with the effusion. Or over on the normal side, again, the acetabulum, femoral head, and then neck. So adults, it's a little clearer. Pediatrics, the first thing you see, you might think it's acetabulum, but that's femoral head. You're looking at the growth plate, so keep scanning, looking for the acetabulum. All right, parenting tip number 2, if they can't walk, no bench pressing. Oh, no, come back. Come back. There we go. So septic arthritis is not the only infectious pathology we've got to worry about in a limping child. Yuen et al. Actually published this analysis using the Coker criteria to evaluate for osteomyelitis. So they found if you had 3 or 4 positive Coker criteria, you were twice as likely to have osteomyelitis as you were to have septic arthritis. And then if we introduce ultrasound, if you had an effusion, you were just as likely to have osteomyelitis as you were to have septic arthritis. In fact, you're more likely to have both. Where I think this study is more helpful is that if you didn't have an effusion, you were much more likely to have osteomyelitis. So if you've got a pediatric patient, you do a bedside ultrasound, you don't see an effusion, but they have fever, they can't weight bear, you probably need to follow up with an MRI to make sure that they don't have osteomyelitis. So again, another part of using point-of-care ultrasound to help you decide what to do next. So this is my own practice. There's not a lot of literature behind this, but I see a limping child come in before any tests get done. I just throw the probe on and I scan their extremity. If they can identify for me where it hurts, great. But if it's a little toddler, sometimes they can't. Sometimes knee pain is referred from the hip, so I don't know where it is. I just scan the extremity. I look at the long bones and ask, is there a fracture? So I look, you can see in the far field this hyperechoic line, and we look for a step off. So we don't see any step off along here, so no fracture. And I look at the joints and I look for an effusion. This is actually, the head is up here and the feet are down here. The knee joint itself is over here, just coming off the screen. And then this is the femur. And here's another growth plate and the metaphysis over here. So this suprapatellar bursa, if there was an effusion, the suprapatellar fat pad, this little triangle, would get lifted up as the effusion tracks out underneath. So no knee pathology here. So then I move up, take a look at the hip, same kid. So again, we can start seeing the femoral head come in at the very end of this clip, right there. Otherwise, we're looking at the femoral neck, and we've got this nice big effusion. You can actually see the outline of the joint capsule. And again, we do want to measure all the way. So some people make the mistake and measure just the effusion. You need to measure from the bone to the muscle. So measure that whole thing. So you want it, it's kind of like aorta, outer to outer. And some folks will actually stop there. If you've got a good story for transient synovitis, this is just case series. There's not really good data. But occasionally I'll do this if a kid's got a great story and they got good follow-up. I see an effusion, I got transient synovitis, I send them home and just call and make sure things are going okay. Not a lot of good evidence for that. Others suggest the opposite, that if you see any effusion, you have to diagnose that. You got to get fluid, you got to culture it, you got to know if there's septic arthritis. So even if you fall into that camp, ultrasound helps you there because it can help guide the needle and you can do a bedside tap of that hip. In the emergency department, we're not doing fluoroscopic guided arthrocentesis, and landmark technique is not only poor, but it's actually dangerous. So this study compared both the anterior and lateral approach, and in the anterior approach, a really significant percentage of patients actually pierced or hit the femoral nerve. So you should be using ultrasound if you're tapping any joint. You know, even knee joints, you can actually get all the fluid out, right? And they'll have improved outcomes because they don't have persistent effusion there. So I would always use ultrasound guiding your needle wherever you're placing it. And if you're going to do it under sterile conditions. Keep the probe exactly where you had it before. Take a 20 gauge needle, aim it 45 degrees down into the effusion. But make sure that you see the needle tip the entire time. So if we look at this clip here on the right, this wasn't a state-of-the-art ultrasound machine, so it didn't have needle guidance. Needle guidance steers the beams and now it allows you to see the needle a little bit better. And we're seeing that the needle as it's kind of tenting the joint capsule about to enter into the effusion, but you can't actually see the needle tip, and that's not ideal. You want to see where you're going. If we look at an adult hip being tapped, same problem. You can see the needle tip. It's actually coming up towards the femoral head. We'd like it to be down here on the neck a little bit better. So how do we avoid this? So this is the concept of anisotropy again. Got to hit things perpendicularly. So if we use our ultrasound and it sends out the ultrasound waves, it hits the needle, it's going to bounce off, and we're not going to get all the waves back. We're not going to get a very clear picture. So how can we overcome this if you don't have a modern machine that has the needle guidance? You can drop the angle of the needle. You can do some heel toe, and you can push the probe down, kind of lift up where the needle's entering into the skin. And that allows you to get a little clearer image as it comes back to the probe. So we know that ultrasound is useful for helping us identify effusion. It's useful for helping us tap the effusion. Then you might ask yourself, well, how often are they actually septic arthritis? I'm never going to tap this hip. Well, someone got through an IRB, a study where they said, these patients have transient synovitis, and we're going to tap them all just to see if they feel better. And this study, oh no, come back. They used bed rest, standard of care bed rest plus NSAIDs versus the aspiration plus NSAIDs, and they found that the bed rest group, about 14% had refusal to bear weight. Only 1% in the aspiration group. The majority in the standard of care group, the bed rest, had pain versus only 6% in the aspiration group. And at 24 hours, almost everyone was limping in the standard of care group versus 10% in the aspiration group. And the duration of illness was shorter as well. So if you believe this literature, it becomes a little bit easier to make the diagnostic decision to perform arthrocentesis. And the 4-year-old that we were looking at earlier, that patient, when they woke up from the ketamine sedation, they gave us a high five. They said, I feel all better, and they walked out of the ED after their initial test came back looking fine. All right, one more. Parenting tip number 3, rear-facing car seats are preferred. Let's shift gears here. We'll talk about POCUS evaluation of SCFE. And here, again, small studies, primarily case series and small trials. But this one compared ultrasound to CT and found that it is very sensitive and specific for SCFE itself. So you can use it for diagnosis, but researchers have been able to correlate the traditional definitions of severity of SCFE with ultrasound measurements. And here, if we look at this image, we can see the femoral head down on the left. So head is up here, feet are down here, and then we see growth plate. And then the femoral neck is coming off the screen. So if you just were to walk along the femoral neck, and then you reach the growth plate, and you step down, that's SCFE. So it's that step down, it's that slip that tells you that they're SCFE. But not only is it useful for the diagnosis, some think that you can pick it up potentially earlier, but maybe more importantly, you can tell if it's unstable. So the traditional diagnosis of unstable and acute was defined by this probably doctor named Loader. And unstable was anyone that couldn't ambulate, even if they were using crutches. Acute was any symptoms within 3 weeks. So if it was more than 3 weeks, it was considered chronic. But here with ultrasound, if you see an effusion, you think it's probably acute. If it's acute, it's probably unstable. So it gives you some sense of giving patients some prognosis and making sure that they really stay off of it. And here's another example. So our normal, again, if we walk down the femoral neck, we just keep walking across the growth plate, and we just walk down the slope. Over here, we see an effusion at the femoral neck, so we know it's acute, so it's probably unstable. And as they walk down the femoral neck, you have to step down once you hit the growth plate onto the femoral head. All right, this is the last one. Look before you feel. All right, last thing. Is there any utility for leg calf Perthes disease? Well, not of all the things I presented, probably this has the least data behind it. So one potential use is actually contrast-enhanced ultrasound for prognosis. So here They haven't been able to find that it was as good as scintigraphy. So on the right here, this is still the gold standard. But you can't do this very often, and it's a lot of radiation. On the left, this is a regular ultrasound, but here in the center, you can actually see with contrast-enhanced ultrasound, you can see more blood flow, you can see the revascularization. And this author thought that contrast-enhanced ultrasound might be good for monitoring and being able to see the chronology of healing and do some tissue mapping of the femoral head. However, it's certainly not ready for POCUS prime time. And personally, I think if we're going to do any contrast-enhanced ultrasound, it's probably going to be with a fast exam first. That's a whole other talk. Here are my references. And thank you guys for coming. If you have any questions, happy to answer. Have a good day. Yeah, Dan.
So when you tap your joints, are you fully sterile, or what's your?
Yeah.
Because this is like a one-time in and out. So.
Right. I do. So since I'm teaching in residence, I go the extra mile and I make them pretend like they're in the OR, just because I don't want anything to come back on us, and I don't want controversies. It's just not worth it. You're revitalating a joint. If at any point there's any question, I want it to be clear. We gowned up. We did it sterile. And I think that's just the safest way to go.
So you're gowned with a...
Yeah, gown and hat and lay it all out. I mean, in my own practice, have I done it the other way and just cleaned and put a needle in? Yeah. But it's a little kid. We're sedating him. It's a big deal. So I would gown up and do it the right way.
Yeah, one study presented transient Synovitis.
Yeah.
Were there any complications, the ones who got tapped?
No. And I can give you that. Here you go. So if you guys use your QR, your iPhone, you can pull that one up. But no. The complication rate was the same for both, and there wasn't any.
Yeah. Like, you talked about the different levels of
Severity?
Severity.
Yeah.
Is there like measurements associated with those?
Right.
And then where are the measurement points that you were using for that?
So that's a good question. It's just the degree of that slip, that degree of that step down that you take. Sorry, I'm going the wrong way.
Are you throwing the line out from
Just from the femoral neck, right at the growth plate, and then that you're measuring that step down. So here's the measurements. So you're just going to measure from once the growth plate starts down to this step of the femoral head. So this distance right there.
So along the actual
Yep.
itself.
Yeah, along that growth plate. No. Yeah. Yeah.
For infusions, at what age cutoff are you transitioning from 5 to 7? Are you using like 18? Is that?
That's a good question. I think most of the literature will be 17 or 18, depending on the research study. So I'm going to compare the other side, and if it's abnormal, it's abnormal. Some MSK radiologists will also use the 2 millimeters for adults, but that's not as defined as it is in pediatrics. Good question. All right. Thanks, everyone.